Welcome to those of you in the U.S. and to those here in the early morning hours in Asia. We are glad to have you with us, and we are sitting with the doctoral students in the Asia Graduate School of Theology.
Bill, I'm so sorry, but like people are clearing their throats and other things, so I think that not everybody is muted, unless you're clearing your throat, which you aren't.
No, I'm not. No, not yet.
So maybe everybody, or maybe the BSO, of course, that's where you are, Bill. You need to be able to talk. Well,
Right.
anyway, okay.
Okay, for the third time. Welcome to everybody in the U.S. It's your evening and it's early morning here, and we are in the classroom with the doctoral students of the Asia Graduate School of Theology and the Biblical Seminary of the Philippines, where we are presently seated. Our class in our program is basically in psychodynamic psychotherapy, and we follow Fairbairn and all the other people in
Karen Horney.
Karen, yeah, my mother into psychoanalytic thinking was Karen Horney. My father into psychoanalytic thinking was James Masterson, and my grandmother into psychoanalytic thinking is Martha Stark.
Oh.
What can I say about Martha? Good heavens. She's a friend. You all know her. She is always there to help and to give support, instruction. No words really capture it. By the way, hello to my wife, who is also on the US side. She was not able to make the trip over. So with no more details, oh, yes.
It's real expertise, skill.
The program is being recorded so that those that can't make it in the US in the evening, or those that can't make it over here in the morning, it will be recorded and we will send it, or she will send it to you. And it's also here, I have it mine printed out. There's a PDF that you can print following along. So I'm going to keep the introduction very brief.
And we want everybody muted. People aren't really muting themselves. So somebody, please, to be in charge of that. Jeffrey and others, please.
Do we mute from our side or from their
Oh,
side?
you do. Yeah, I think you do. Your tech fellow and there also seems to be the sound of some background sound like.
Yeah, there was for a moment, yes. No, there isn't still a little bit.
Yeah, and
Is it in here? Somebody in here isn't muted.
Oh.
Everybody.
Yeah.
Okay, here's our IT expert helping us.
Yeah, now we got that echo. Oh, look. Well, it gives me a chance to take a look real quick, like, oh, wow, seeing the people who are here. And I'll call you out if you're not muted. Oh, look, hello, you all. Hello, Giselle. Hello, Giselle.
Okay.
Okay, good. Yeah.
All right, I'm not going to give the introduction for the fifth time. Martha.
Well, how about we say, I love Bill and Midge Kirwan, and they have been very dear to me over the course of the years, and I absolutely adore them. So for me to be presenting tonight, this morning, what have you, is very special for me, and I could not be more thrilled. So thank you, Bill and Midge.
Well,
and Tyne.
It's
Yes.
mutual. And as my grandmother into psychoanalysis, we thank you and for being part of our program. She is officially adjunct faculty to you guys, to the program sitting in front of me. All right, I'm going to keep this very brief because we want to get on. She's a graduate of Harvard Medical School and the Boston Psychoanalytic Institute, and teaches at Harvard and has many other teaching places, and Martha can tell you about that. She has many books. One, I went up to try to find it in our library and I couldn't. I have two of them in the US, is Resistance. Now that's been out for a long time, the book Resistance, but it's considered a monumental book in psychodynamic psychotherapy. always a required reading in any program. Another well-known book endorsed by Stephen Mitchell, who's one of the very giants in our field, is Modes of Therapeutic Action. And you're getting that in, we've been over that time and time again. So without further ado, Martha, thank you for being here and we welcome you and it's all yours. Thank you.
Oh, bless you. Thank you so much. Again, I am so happy about being here. All right. So the big, long, complicated title. Now, let me just say, I have spent hours and hours and hours crisping and refining these slides. And in the process, I came to understand much better my concept of relentless hope. Sort of like I've had the concept for 30 or 35 years, been writing about it, et cetera, and it's a good thing that I have now come to understand it. So that's a good thing. So I think I'm just going to say here, navigating the relentless hope of patients with borderline dynamics, an integrative approach to developing evocative memory, mentalization, and the capacity to grieve. In essence, I'm going to be talking about from relentless hope to realistic hope and self-sustaining resilience. People sometimes say, but hope is a good thing, right? Sort of like, well, yeah, reality-based hope is, mature hope is, relentless hope can get you in trouble. Oh dear, okay. All right. All young children, this slide, it took me about 100 hours to write this slide. All young children, as a normal phase of development, hold the idealized fantasy of perfect caregiving, perfect attunement, perfect mirroring, perfect responsiveness. If development proceeds as it should, they will gradually advance incrementally from the defensive need for external caregiving, caregiving from the outside, to the adaptive capacity for internal caregiving, caregiving from within. Now, what makes this shift possible? Through the normal developmental process of encountering and mastering the inevitable slings and arrows of imperfect caregiving.
Pictures.
Could people mute themselves, please? Thanks. So the inevitable slings and arrows of imperfect caregiving, the tolerable, Dr. Mark Yates, thanks, the tolerable, optimally frustrating, growth promoting experience of being periodically failed. Let me say that again, sorry, because that was a sentence I spent 100 hours on. Through the normal developmental process of encountering and mastering the inevitable slings and arrows of imperfect caregiving, the tolerable, optimally frustrating, growth promoting experience of being periodically failed, the need for perfect idealized caregiving will be gradually tamed, modified, and integrated when all goes well. And as a felicitous result, the child will begin to develop the capacity to provide good enough caregiving from within. Good enough. So from the need for external caregiving that is perfect, idealized, to the capacity for good enough caregiving or approximately perfect. And let me give you the example that I often present here. It's an old-fashioned one, forgive me, because it has to do not with cell phones, but telephones on the wall. So there's mommy, maybe it could be daddy, but for the moment, let's say mommy. Mommy is holding her very little baby and rocking her little baby back and forth, and the little baby is cooing so happily. It's all good, it's all good. And then the damn phone rings in the other room. So mommy reluctantly puts the little baby in the crib and goes to answer the phone in the kitchen. And the little baby is devastated, abandoned, alone, panicked, terrified, so very upset. But mother finishes up real quick, like comes back, picks up the little one, rocks him again, picks him up, rocks him back and forth. And now, it's all good. Little baby cooing and it's all good, it's all good. But then the damn phone rings again. And so the mother goes and picks that up. Now the little one in the crib, for a few moments, has these sort of implicit relational knowing, if we talk about Carlin Lyons rules, they're just implicit something, sort of nonverbal, deep down within, for a few moments of mommy go, but mommy come back. And then starts, so for a few moments, and then starts crying. Mommy comes back. And this happens by way of a series of being periodically failed, but mommy comes back. And so ultimately, these are tolerable, optimally frustrating, growth promoting failures, periodic failures, as a result of which the child will begin to develop from within adaptively. And it's adaptive because the little one on some very subliminal, deep, deep level is sort of getting that you can't always count on the outside to provide it. So therefore, adaptively, you decide this is normal, healthy development. You sort of get it that maybe you better start providing some of it for yourself. And again, throughout, we're going to be talking about from defensive need, less good, to adaptive capacity, more good, more evolved. Okay. All right, now more specifically, the shift occurs as the child adaptively internalizes. And in the literature, though most people don't still stick to this tradition, I do, but that's because I'm a little compulsive. But we talk about defensive introjection of bad, pathogenic introjects, defensive introjection of bad, charged toxic boluses, but adaptive internalization, or even transmuting structure building internalizations of good, of self-object functions, adaptive internalization. That's a good thing. And you do that when you've been able to grieve. So what do I have here? So this shift occurs, normal, healthy development, as the child adaptively internalizes the caregiver's self-object functions, functions that will provide containment, important word here, mirroring, affirmation, restoration of the self. All right. So this is when all goes well. These internalized capacities will enable the child to preserve inside pieces of the original experience of external goodness. Now, this tempering of the longing for flawless caregiving signals a movement from reliance on others for self-esteem regulation, or it's called self-regulation in the literature, to self-sustaining resilience. Once enhanced from the self-object, once the self-esteem was enhanced from the self-object, the self-esteem will now be generated from within. So you're no longer normal development, continuously needing validation, affirmation, mirroring, restoration, containment, because you have developed the capacity. Once borrowed, it will now be owned. That's when all goes well. So that's the first of 3 possibilities. That's number 1. Oh dear. All right. All right. Now, but patients with unresolved narcissistic issues, which in essence, for some of you, sort of, oh, yeah. And for others of you, what the hell is that? But anyway, featured in Model 2, the corrective provision perspective of self-psychology. Anyway, patients with unresolved narcissistic issues, featured in Model 2 of the Stark method of psychodynamic synergy. Please note the way I got the star in the middle there. My last name finally counts for something. I can put a star in the middle. But patients with unresolved narcissistic issues have never fully outgrown their need for perfect attunement, mirroring, and responsiveness. They have relentless hope, which I get to in a second. When very young, their infantile need for perfection was entirely age appropriate, no problem. But because of early disruption in the evolution of this narcissistic need for perfection, that is, because of traumatic thwarting, not optimal, but traumatic frustration, traumatic thwarting by the caregiver early on, the need became defensively reinforced because it wasn't satisfied or worked through or mastered. Thus, sorry, the child never had the opportunity to temper. Oh, I'm so sorry, frog in my throat. Thus, the child never had the opportunity to temper this need for perfection into the adaptive capacity to be satisfied with the approximately perfect. So now, as an adult, their refusal. This is relentless hope. Model 2, featured in Model 2. And all of us, by the way, you maybe haven't heard me saying this, but my Stark method of psychodynamic synergy features 5 models. I'll say real quick, like, all of which are relevant for all of us all of the time. But Model 1, the interpretive perspective of classical psychoanalysis, more cognitive. Model 2, the corrective provision or deficiency compensation perspective of self-psychology, more affective. Model 3, the intersubjective perspective of contemporary relational theory. Think William Allenson White Institute and plenty of others. And that's more relational. So we have cognitive, Model 1, affective, Model 2, and relational, Model 3. Now, Model 4 is an existential humanistic approach to healing brokenness and relentless despair. And now this is a more existential, the search for meaning. So we have CARE, get it, care, CARE. And the 5th mode of therapeutic action is quantum neuroscientific. And now this one is more sort of synaptic and superpositional. Those are very big words, whatever. But anyway, so it's a CARES approach, 5 different ways of helping the patient advance from rigidity, psychological rigidity, to more psychological flexibility. And I'm lifting from ACT, acceptance and commitment therapy, from psychological rigidity to psychological flexibility, they say, or resilience. And I think that on some level, all of the different approaches that we have are about evolving from rigidity to resilience. All right. Anyway. So Model 2, all right, when very young, these folks, yes, had their infantile need for perfection, entirely age appropriate. But because of early disruption in the evolution of this narcissistic need for perfection, in other words, it was traumatically thwarted, the need becomes defensively reinforced. Their refusal as an adult to accept the inevitability of imperfection imprisons them in an unrelenting, unwavering, unyielding pursuit of the illusion that perfect caregiving might yet be forthcoming. This is relentless hope. When a panel of 10,000 objective judges would have said, forget it, it's not going to happen, and yet the person keeps hoping. And it's an interesting, wonderful concept. And patients will often say, so I know I keep hoping, and sort of like, yeah, that Albert Einstein thing, insanity, doing the same thing over and over again and expecting a different outcome. Well, how about relentless hope, being the same thing, doing over and over again and expecting this time that you'll get the perfect caregiving that you've never relinquished your need for. So their relentless search reflects an adamant refusal. It's a refusal to accept I like these 3 words, I've carefully chosen them, limitations or inadequacies or imperfections, separateness, and unyielding immutability, the fact that they can't be forced to change, of the objects of their ceaseless desire. Again, whether it's contemporary objects or the infantile objects or the transference object. So even though at heart their pursuit, really important, this sentence, is for something that never truly existed. It was, they didn't get the perfect attunement, the perfect mirroring, the perfect responsiveness. It was traumatically thwarted. And so they've been, ever since, it was defensively reinforced, that need, and ever since in pursuit of it. And it plays out in any number of areas. You want it from your boss, you want it from your children, from your parents, from your therapist, from your partner. Okay, sorry, it's not working quite right. And yet, change is possible. There is hope, realistic hope. When such patients present to treatment, here we go, there will finally be an opening. These are Model 2 people with the relentless hope, narcissism, unmastered. There will finally be an opening, albeit a belated one, because psychotherapy is about belated impetus and opportunity to do now what was not done early on. There will finally be an opportunity, an opening to confront and grieve, confront and mourn. I don't tend to use the word mourn, but that works too. To confront and grieve the unbearably painful reality of an object's lack of perfection. That they've held within them all this time, as embodied now in the self-object therapist. And again, we talk about narcissistic self-object, in parentheses, transferences on the one hand. In model 1, by the way, we talk about neurotic drive object, in parentheses, transferences. Very different concept. So model 1, neurotic drive object transferences. Model 2, narcissistic self-object transferences. In model 1, the therapist is a drive object that gratifies or frustrates, drives. In model 2, the therapist as a self-object who's sort of embodying sort of idealized perfection and wishing and hoping and praying that you'll get the mirroring, the responsiveness, the attunement. Okay. In the treatment, they will therefore be able to work through empathic failures by the self-object therapist. I'm just kind of copying off of self-psychology here. Disruptions of the narcissistic self-object transference. And to benefit from that disillusionment, these optimal growth provoking, I'm not even saying growth promoting, I'm going to say growth now in the treatment, growth provoking. They provide impetus and opportunity, disillusionments by, let me say again, so therefore be able to work through the empathic failures and to benefit from that disillusionment by adaptively internalizing whatever good had once existed in the therapeutic relationship. In this way, they will preserve within themselves a trace of the original experience of the therapist's external goodness. It's adaptive, yes, as a consequence of their grieving. In other words, for patients with unresolved narcissistic issues, development of self-structure, as we call it, self-esteem regulating a structure, filling in of self-deficits, as it's called, and quenching of thirst for external narcissistic supplies, mirroring attunement, unconditional love, all that good stuff, will become possible as a result of the therapeutic process. A process that will involve, admittedly, a prolonged working through of optimally frustrated narcissistic needs experienced in relation to an idealized but ultimately imperfect self-object therapist. All right. Now, that was the second category, model 2. Now we're going to talk about model 3. And more specifically, patients with borderline dynamics, patients with unmastered borderline dynamics, featured in Model 3, the intersubjective perspective of contemporary relational theory, right? William Alanson White Institute, Stephen Mitchell, Jay Greenberg, and all of those other wonderful people have also never relinquished their fantasy of perfect, idealized caregiving. But the quality of their yearning is different. Subtly different, more anguished, more tormented, more despairing. Why? Because they are longing to recapture something that might once have existed, even if fleetingly and perhaps only in fantasy, but that has since been irrevocably lost. Get that? So in the second category, Model 2, they never had it, but they've always wanted it. In Model 3, and we'll explain a little bit more about what some of the people in the literature, Melanie Klein and Margaret Mahler, say about why it is that early on they actually did have some magical moments of connection, and then they didn't, and then they did, and then they didn't. Think Fairbairn's seductive, exciting, rejecting mother, and so on. But anyway, because these patients with borderline dynamics are longing to recapture something that might once have existed, even if for brief moments, perhaps even only in fantasy, the illusion, but they had something. And I love to work with borderlines, actually. And when I was doing my training at the Cambridge Health Alliance decades ago, I was on, Luis Sanchez and I were on the same team. And the luck of the draw, he got all the schizophrenics and I got all the borderlines. So I was like carrying, like 30 borderlines at once. And so you learn a certain kind of way to kind of handle it and not get like totally bent out of shape. If they say like, oh my God, I'm going to kill myself, it's like, whatever. So anyway, and I ever since, borderlines is sort of one of my specialties. I don't know that I've always wanted to let everybody know that, because people will, over the years, will say, Martha, I have a very interesting patient for you. Read that as I have a patient with borderline dynamics, but that's okay. There's a way in which they can connect in a way that's really very profound and very, very powerful, very powerful. You got to get them contained though, and we'll get to that in a moment. All right. And anyway, so theirs in Model 3 here, theirs is an intense yearning to reclaim an idealized past that is now irretrievable, a paradise lost and never restored. Yet their proneness to, these are some problems that we're going to have to fix, defensive splitting, fragile evocative memory, and tenuous capacity for mentalization. Three things: defensive splitting, fragile evocative memory, and tenuous capacity for mentalization will seriously compromise their ability to grieve. That's a big deal because in order to relinquish your relentless hope, you need to be able to confront and grieve the reality of the object's limitations, separateness, and immutability, the fact that they can't be forced to change. And these patients, I'm sorry, it's so dry in here. Sorry. Of course, it's dry because I'm not a total victim. I had turned up the heat. It was very cold outside, and I did turn up the heat, and now it's dry in here. Oh, well. All right. Anyway, So the defensive splitting, right, the fragile evocative memory capacity, meaning that in the moment of upset, they can't remember the good that had been, and tenuous capacity for mentalization. They have a defective capacity. It's not fully developed to sort of think about their own or other people's emotional states and how those emotional states, feelings, thoughts, intentions, motivations might be impacting their own and others' actions and behaviors. So that's that they're not able to sort of think about that and process it, which makes it complicated. So therefore, it compromises their ability to grieve. For them, therefore, the development of self-structure so that good enough caregiving can ultimately be provided from within, that's the goal here, rather than relentlessly pursued from without, will involve not so much the working through of optimal frustration, which on the previous slides I was talking about, but rather the emergence from within of a lived experience that is altogether different. Oh my God. All right. Tragically, and this, I think this last slide in this section, tragically caught in the web of their relentless, anguished, desperate pursuit, they will unfortunately find it profoundly challenging, these patients with borderline, unmastered borderline dynamics, and quite daunting to engage in deep embodied therapeutic work. Because for them, every empathic failure by the self-object therapist will be experienced not as an optimal, and in self-psychology, and as I'm using it too, optimal means non-traumatic and can be grieved, and then adaptively self-object functions are internalized, right? But for these people, every empathic failure by the self-object therapist, because it can't be grieved, will be experienced not as an optimal non-traumatic disillusionment, the kind that sparks growth and filling in of deficit and relinquishment of relentless hope through adaptive internalization of the good that had been, but as a traumatic disillusionment from which recovery feels nearly impossible. In other words, for patients with borderline dynamics whose evocative memory in the face of relational disappointment is not yet firmly established, there is no such thing as optimal frustration. Every disappointment of whatever magnitude will be experienced as traumatic, one that cannot be mastered, cannot be grieved. For those vulnerable to defensive splitting, and seriously compromised by fragile evocative memory and tenuous mentalizing capacity, those three things there, every disillusionment becomes a traumatic one. Oh, yes, and just wanted to say, there is this conference in November that I'm going to be on a panel with, Be Still My Beating Nervous Heart, Peter Fonagy and Nancy McWilliams. That's me in the middle. And thank you, Lois Choi King, who kind of put the whole thing together. All right, so Now, real quick, like on these two slides, many patients struggle, at least to some degree, with emotional dysregulation and insecure attachment, precariously established self-esteem, distortions in self-concept, trust issues, and relational dysfunction. But as I will be suggesting throughout, patients with borderline dynamics carry an additional layer of nuance and complexity, characterized by profound psychic fragility, emotional volatility, interpersonal hypersensitivity, dysregulated impulsivity, defensive splitting, anguished heartbreak, and a pervasive sense of betrayal. These elements fuel a uniquely grief-stricken, tormented, fragmented, internally chaotic, and often crisis-ridden existence. These are the people who are often talking and wanting to kill themselves. And of course, it's usually on a Friday afternoon and at the beginning of a long weekend. The patient's fractured experience of being is such that intense emotions feel like maelstroms, each a turbulent, all-consuming force, et cetera, et cetera. All right, now working with these patients in treatment then is especially demanding, although ultimately extraordinarily rewarding. They can quickly become formidable opponents, and whenever sort of triggered, it leads to the well-known and almost inevitable enacting of their crushing pain. I guess we don't really say so much acting out anymore. We want to dignify it a little more and say enacting or reenacting sometimes, of their crushing pain, profound despair, and entitled outrage. All of this notwithstanding, their tender, soulful vulnerability, their exquisite sensitivity, passionate intensity, disarming authenticity, and gift for deep relational presence, when able to feel safely held and truly seen, make of them at times a sheer pleasure and absolute delight to engage with in treatment. The longing, the fear of abandonment, the intensity, the tenderness beneath the rage. Okay, I'm going to just, my eyes on the time, and for the moment, you have it in your slides, although I did change it around a little bit. I'm so busy evolving in my thinking, or so I imagine I'm evolving in my thinking, although people hear me sometimes say, oh, you were saying that 30 years ago. And meanwhile, I think I'm saying stuff differently from the way I'd said it yesterday. So much for that. Anyway, well, I'll just say this, read this slide. Melanie Klein, The Paranoid Schizoid Position, Pre-Ambivalence, and then advancing to the depressive position, ambivalence. And many have suggested, Melanie Klein in particular, that the borderline is sort of hasn't really done a great job of advancing beyond the paranoid schizoid position, which is a pre-ambivalent developmental stage in which others are experienced as part objects, either as need gratifying, all good, or need frustrating, all bad. This period is marked by ruthlessness, and when interpersonally stressed, patients with borderline tendencies who might otherwise have been doing okay, but when interpersonally stressed or there's the threat of emotional overwhelm, they will frequently revert to this early pre-ambivalent stance. Okay, so there you go. All right, now Margaret Mahler. She, of course, the separation individuation process, and most especially the rapprochement subphase, is implicated in the development of borderline psychopathology. This period, 15 to 24 months, is especially critical, this rapprochement subphase, because it is during this time that the young child is torn between the push-pull of independence, autonomy on the one hand, and closeness on the other. Struggling to move away from the mother, yet still needing her for emotional refueling. And as a result, the child is particularly susceptible to developing intense anxiety, fear of abandonment, and heightened dependence on the caregiver for reassurance. So that's what Margaret Mahler talks about with respect to borderlines. Okay, so the caregiver, often a borderline, organized around a borderline structure herself, will enact a pattern often of radical inconsistency, at times smotheringly present and psychically engulfing. And we talk about the so-called smother mother. And at other times, although to be more politically correct, we'd say smother caregiver. but whatever. And at other times, inaccessible, withdrawn, or emotionally absent. So mother will alternate between being overprotective, intrusive, and demanding, and then hostile, rejecting, and emotionally distant. And the caregiver's seductiveness, right, Fairbairn's seductive mother, who alternates between excitement and rejection of her child, is understandably a source of profound distress for the vulnerable child. It offers the child the fleeting experience of being able, at least for brief periods, to bask in the warm glow of something deeply cherished, only then to have it inexplicably and inevitably wrenched away again and again. And so then, once the child ventures out into the world, she will carry deep within her a desperate longing to reclaim that which had once belonged to her, even if only briefly and primarily in fantasy, but that which can no longer be found. An idealized past that no longer exists in its original form, or perhaps never truly existed at all. It's an idealized past that is irretrievable. Different from Model 2, they never had it. They just sort of imagined and yearned and longed and wished to have the idealized, perfect idealized caregiving. For these folks in Model 3, especially patients with unmastered borderline dynamics, a paradise lost, never to be recovered. Okay, and Peter Fonagy. All right, so Peter Fonagy, introduced, just brilliantly, and it's sort of like I was Johnny come lately on this one. It's sort of like, yeah, I know about mentalization. I'd never fully realized that mentalization, one, is critically important for all people, but especially important, by the way, for Model 3, negotiating at the intersubjective perspective, William Allenson White Institute, negotiating at Darlene Ehrenberg's intimate edge, and mentalizing, where the two, patient and therapist, caught in a sort of transference, countertransference, messiness, as Ed Tronick and Claudia Gold call it, and mutual enactment, and the way out of those projective identifications will be, by way of certainty, the therapist's capacity to mentalize, and then ultimately, because mentalize, I guess, can be used as a transitive verb, mentalize the patient. And so together they talk about and process what's happening at their intimate edge. Anyway, Peter Fonagy, this capacity, mentalizing capacity, is a hard-earned developmental achievement. Not everybody gets there. And it's relevant for patients with borderline features, and really for all of us. Now that I'm sort of onto it, it's sort of like I see it in myself, I see it in all my patients, I see it in the world. Well, look at the political situation, you just see it everywhere. Anyway, this capacity, hard-earned developmental achievement that reflects, here we go, the ability to create and use mental representations of both one's own and others' emotional states, feelings, thoughts, beliefs, desires, intentions, motivations, as well as to observe, understand, and interpret actions and behaviors, both one's own and others, as expressions of underlying mental states, mentalization, mental states. The concept of mentalization speaks to adaptive integration of cognitive, so more mental awareness, affective experience, more heart affect, and behavioral expression. So it sort of functions across all three domains: thought, feeling, and action. In essence, mentalization is the capacity to imagine, interpret, and make meaning of the inner worlds of self and others, and to understand how these internal states shape behavior. In their landmark 2004 paper, Mentalization-Based Treatment, MBT, of BPD, Peter Fonagy and Anthony Bateman, he has numbers of colleagues over there in the UK, outlined a new approach to treating patients with borderline features. Their MBT, rooted in attachment theory, is informed by the observation that patients with BPD, borderline personality disorder, often lack a reliable, it's tenuous, capacity to mentalize, primarily because, say they, and says Peter Fonagy in particular, because of inadequate attuned mirroring in the early attachment relationship. More specifically, such patients, Fonagy and the others say, lack a stable foundation for mentalization because the early caregiver had difficulty providing, their words, contingent and marked affective displays in response to the infant's subjective experience. In other words, the caregiver struggled to provide attuned responses that were both appropriate and clearly signaled. The bidirectional nature of mentalizing, bidirectional, is therefore central to how Peter Fonagy and his colleagues understand, in quotes, its developmental origins, how it came to be, and formulate then the treatment, a reversal, or providing now what wasn't done early on, and the treatment targets. The goal is to get there. So the process and then the goal. So it's both the journey and the destination for the psychotherapy of patients with BPD. A few quotes real quick, like, the objective of reaching a state of improved mentalizing in the patient is reached through an interactional process, say they, whereby the therapist models their own mentalizing capacities and demonstrates their ability to mentalize the patient. Transitive verb there. And finally, in MBTs, the therapist will mirror the patient's emotion, but in a slightly exaggerated or caricatured fashion. And I realized in my spot supervision Zoom session, entirely free today, that I was doing, we were talking about it, and pointed out that sometimes what we do as we're listening, in order to help the patient sort of become better able to create mental representation of what's going on for them cognitively, affectively, and behaviorally, is that we will respond in a slightly exaggerated or caricatured fashion, but such that the patient can recognize it as both reflection and modeling, rather than the caregiver's own emotion fully taking over. So, I mean, if you say like, oh my God, it's not that sort of like you are just like so overwhelmed that you can hardly stand it, but you do it in such a way that it's a reflection of sort of what they're not quite yet letting themselves do, and modeling for them what ultimately we would hope they can do. Okay, here we go. The capacity to grieve is central to the relinquishment of relentless hope. Okay, now this slide doesn't entirely fit, but I just love it so much, I just stuck it in here. Moving on as a concept is for stupid people, because any sensible person, said Max Porter, knows grief is a long-term project. And I know it's all, if you have the death of someone very near and dear to you, and then people say, well, how are they doing? How are they doing since the death? What is the right answer for, oh, they're doing okay. Well, they're still grieving. Oh, I mean, moving on. Are they moving on? I hope not. That's for stupid people, because any sensible person knows that grieving, the process of grieving, is a long-term project. And for any of us who have lost important, significant people in our lives and have manage somehow to do appropriate grieving, you don't just like sort of like move on. Yeah, it takes time. All right, now if all goes as it should, this is when all goes well. When patients experience a loss, whether real or merely perceived, because the brain doesn't really know the difference between reality and imagination, which is kind of cool. You can set intention for all sorts of stuff and the brain thinks it's real. And that's actually at the heart of my Model 5, quantum disentanglement statements, where you're trying to extricate the patient energetically from the toxicity of the past, and you have them imagine what they would wish could be something different, better, and compellingly better for the future. Anyway, when patients experience a loss, they must ultimately confront the painful truth that something they once had is now gone. This facing of the truth and evolving toward sober, mature acceptance that it was what it was, is what it is, and will be what it will be, is an essential part of the grieving process. Indeed, if patients are ever to move beyond their experience of bereavement, or loss, or not having something, relentless hope, they must face and ultimately accept that something has changed forever, or something that they'd been yearning to have is not going to happen. As part of grieving, genuine grieving, patients will adapt by taking in the good that had existed prior to the loss. I've said that. In the self-psychological literature. Now, some of the self-psychologists absolutely endorse this and some don't. Some are more about just provide more of the good stuff and not as much about helping patients master their experience of disillusionment and disappointment. It's kind of divided a little bit, I think. But for those who do think in terms of mastering disillusionment, disruptions of the narcissistic self-object transference, they talk about, and it's the example I gave at the beginning of the adaptive internalization when mommy goes to the damn phone in the other room and the little baby eventually adaptively internalizes the experience of goes but comes back, goes but comes back. Anyway, it's described as adaptive transmuting, meaning structure building or capacity building, internalization. Remember, defensive introjection of bad, adaptive internalization of good, self-object functions, an inevitable and felicitous accompaniment of genuine grieving. And this is where I always say, in my time, I've tried to sometimes explain to patients this concept, and I've made a fool of myself. So they will say, I came here to get the good stuff that I never got early on. So if we try to say, oh, well, the good stuff, that'll be the backdrop, but it's really going to be you're working through your disappointment that you won't always get the good stuff. That's the way in which adaptively you internalize the good that was, and that's the way you'll fill in deficits, and that's the solution. I've tried that a few times, relentlessly hoping that maybe patients would sort of, oh, so that's what it is. And sort of like, well, you make a fool of yourself if you try that. So, all right, so moving on. The capacity to grieve is therefore central to the relinquishment of relentless hope. And let me say, the thing that just doesn't get done enough of is grieving. And as I think about some of the cases presented in the spot supervision, I think about with my own patients where I'm not doing a fabulous job of helping them with their grieving. I have one patient with whom I've worked a long time, and I would have said very well, although the fact that I've worked a long time with her, and she has simply said to me that if I ever say the word grieving again, she's going to quit therapy. And I mean, she's not really going to do that, but let me just say, I'm not going to test it. So I don't even say grieving. I mean, sort of like, okay. And she should be doing the grieving, and she refuses. She's not, no. So we have more work to do. And she knows that, I know that. So the capacity to grieve, it's a capacity, is central to the relinquishment of relentless hope. But importantly, to grieve effectively, patients must have the capacity to remember. That is evocative memory, also called libidinal object constancy, which Margaret Muller also talked about. It's really the same thing. And I've picked up more on the idea of evocative memory. They're sort of the same thing. So I like evocative memory because it sort of brings more to mind the idea of being able to evoke the good that had been in the face of the present bad. And it's a capacity that's not fully established in patients with borderline defenses. Again, sometimes patients with borderline stuff, it's just fine, it's all good. But in the face of emotional overwhelm or upset or disappointment, that's when they can regress and revert to pre-ambivalence and splitting into all good or all bad and more fragmented self, and they lose their capacity to grieve. They can't grieve really. So, but let's see. But when all goes well, the capacity to remember allows the inevitable empathic failures in the therapeutic relationship to be experienced, grieved, and ultimately mastered. And again, I've sort of repeated myself here. And as structural self-deficits are filled in, patients will become better able to be a good enough caregiver unto themselves. All right, I'm kind of repeating myself there. Now, whereas patients with narcissistic defenses are reluctant to grieve, patients with borderline defenses are simply unable to grieve. Lacking firmly established evocative memory and mentalizing capacity, they cannot hold in mind the memory of past good in the face of present bad. Without evocative memory, there's no inner storehouse of good to draw upon in moments of rupture. And without mentalizing, they cannot hold multiple truths simultaneously, the kind of complicated back and forthness of being in relationship. As a result, the psyche defaults to splitting, the only way to manage what otherwise feels unmanageable. In other words, the absence of evocative memory and mentalization leaves patients vulnerable to the tyranny of the moment. It's like they just completely forget the past. So they're vulnerable to the tyranny of the moment. There are some movies about that, right? Where didn't remember the past, and so every day they have to start fresh. Where present pain eclipses past goodness, as defensive splitting replaces adaptive integration, and where every interpersonal disappointment is experienced as intolerable. Imagine living with that. I mean, it makes your heart go out to them. They can't remember. Whereas in Model 2, it's more like they refuse. They could, but they don't want to. They're not going to. No, no. And my patient, who won't let me use the word grieve, she could grieve, but no, she does not want to. These patients, because of their early on history, and because yes, no, yes, no, yes, no, Fairbairn, I always, as does Bill, always think Fairbairn here, seductive, exciting, rejecting, whatever. It's really that in the moment of upset, it was so painful early on, good, bad, good, bad, good, bad, that they don't have a solid internal sense of evocative memory, that they can remember that they've been good. They revert to splitting and defensive splitting. They can't remember. They just can't remember. So one of my interventions is going to be an integration statement where I resonate with how difficult it is for them to remember and difficult it is for them to imagine. Okay, we'll get to that if I can move along here. That means I better move along. Okay, moving along. Development of evocative memory capacity so that past good can be remembered in the face of present bad. Notice that kind of nice little image there. There you go. All right. So, okay. So let me explore now how we as therapists can facilitate the process by which patients held captive by borderline defenses, patients who therefore struggle to remember past gratification in the face of present disappointment, can begin to acquire evocative memory capacity and eventually mentalizing capacity. It is this emergent capacity that will enable such patients to grieve disappointments that once felt ungrievable and gradually to shift from relentless pursuit of the unattainable to fuller acceptance of what is and of what was. Okay, so there are going to be three kinds: containing statements for containment because they have an impaired capacity to be self-containing. They're going to be integration statements because they're prone to defensive splitting in the face of interpersonal disappointment or emotional overwhelm. And thank you, Peter Fonagy, mentalizing statements, mentalization statements. And I have to say, I hope Peter Fonagy will be okay with these. All right. So here we go. Containing statements. Okay. What the patient with BPD most needs is external containment. The therapist as a containing self-object, necessary if the relationship is to continue. You have to have the patient there in order to do it. All right, when disappointed, the patient will experience the once all good gratifying object as all bad and frustrating. Unable to sustain ambivalence, they revert to the pre-ambivalent mode of primitive splitting. So the therapist, once felt to be narcissistically sustaining, will now be experienced as having been lost, both externally and internally, leaving patients overwhelmed by rage, panic, and a terrifying sense of aloneness. Remember the concept of aloneness. And so often the patients don't quite name it. We don't think to name it today in the spot supervision. It was named aloneness that the patient was feeling. Aloneness. It's very powerful. In desperation and lacking the capacity to self-contain, they will be prone to enacting their outrage in a variety of impulsive, destructive, and indulgent ways. And that's part of why so many therapists do not want to work with such patients. All right, let's see. So their inability to handle relational disappointment will fuel their impulse to destroy and to flee from what has become intolerably painful. If the therapeutic relationship is to survive, the therapist must set firm but caring and non-punitive limits, always against the backdrop of demonstrating indestructibility in the face of the patient's attempts to annihilate her. Because the patient suffers from an impaired capacity to be self-containing, she cannot yet provide such containment for herself. All right, so here we go. So I'm going to suggest that the self-object therapist, in her role as a containing self-object, can use what I call a containing statement, a deliberate, interesting spelling of the word deliberate, a deliberate intervention. It's actually a two-part intervention too, as so many of my interventions are, two parts, both sort of anxiety-provoking and anxiety assuaging. So that by the time you're done with the sentence, you can sort of regulate and modulate the level of their anxiety. You can either increase it if you think they have the capacity to tolerate that, or you can really back off and resonate more with their defensive need not to be having you go there. Anyway, a containing statement. Let me clarify. The containing statement is a specific psychotherapeutic tool that proves especially effective with such patients, although it can benefit others as well. For example, suppose the hour has ended and the patient remains seated, unmoving. How might the therapist help the patient leave the office without shaming her or creating a rupture too terrible to bear? So imagine that the therapist, informed by her understanding of self-psychology, decides to respond empathically. So she might then say, "You would wish that you could stay," or perhaps you would wish that you could stay. Certainly a nice thing to say. The patient, feeling both understood and legitimized, nods in agreement, but remains seated. The therapist then recalls that principle of setting firm limits with patients who rely on borderline defenses and have an impaired capacity to provide their own structure. So the value of providing external structure to compensate for the patient's lack of internal structure. And so the therapist says, "I'm sorry, but our time is up and we do have to stop." Delivered with clear, no-nonsense authority. The patient, now enraged, remains seated, rooted to the spot. All righty. My proposal then is use of a containing statement that isn't quite either of those, but uses elements of those. It's an optimally stressful intervention with two parts in which the therapist both supports by resonating empathically with the patient's affect, whatever it is that the therapist senses the patient is feeling in the moment, and also challenges by softly, gently, tenderly reminding the patient of what deep within the patient, albeit reluctantly, the patient does indeed already know to be true. They're not psychotic. They do know stuff. They just really don't want to have to think about it. And so the therapist says, "Perhaps you would wish to stay or wish that you could stay. But as you know, they're not psychotic. Our time is up and we do have to stop." All right, now, let me say, this alone doesn't do magic. However, statements like this said over and over again, eventually the patient sort of gets it. Yeah, you resonate empathically, and then you highlight what they really do know. And I'm going to give you lots of examples. These containing statements first resonate with what the patient is experiencing in the moment, namely the desire to stay, and then gently remind the patient of the reality of the situation, what she knows to be the reality. The time's up. Her time's up. Okay, thereby, and in doing that, we are providing containment, restraint, and limits. So by attuning to the affect the patient is experiencing in the moment, we're attempting to engage her experiencing ego. Sometimes we'll call that the right brain. And by pointing to the reality of the situation, we are attempting to engage her observing ego. So when we say, "But as you know, our time is up and we do have to stop," notice that I've strategically inserted the phrase "as you know," or at times I might say, "as you and I both know." We're intentionally striving to mobilize her observing ego and to foster the emergence of her mentalizing capacity. So by highlighting what she knows at her core, namely her relational accountability, I thank Stephanie Barthmere for kind of reminding me I got to put the word relational in front of accountability. That's relevant for Model 3 here. So by highlighting what she knows at her core, namely her relational accountability, we are challenging her to assume ownership of her actions. We're encouraging her to realize that the locus of control resides within. And by emphasizing this element of choice, we are not reprimanding or shaming her. We are empowering her to reclaim agency over her own inner world, to move from reactive defiance to more reflective, mentalizing ownership. So, from the experience of feeling at the mercy of her impulses to acknowledgement of her own inner authority. We're trying to do that with a series of these containing statements. Okay, perhaps dual awareness is being fostered. Yeah, okay, good. Dual awareness, you got that. And in fact, all of my, at the bottom here, prototypical statements in my 5 modes of therapeutic action are optimally stressful, growth incentivizing. They create mismatch experiences, creating thereby homeostatic imbalance and internal tension. And it's the wisdom of the body that sort of needs to sort of re-equilibrate and work through that dissonance such that there can be a restoration of something, but at a higher, more evolved level, hopefully. All right, so let's see. There's a nice image. Analytic wisdom of the observing ego and the emotional relational wisdom of the experiencing ego. And of course, EMDR, I always have to say this, I do EMDR, but I don't do it that well. I have to read from my little sheet of paper and sort of like SUD. So on a scale from to 10, what is your SUD? And so on. So anyway, but quite frankly, around targeted somethings, even I, with not knowing how to do it that well, can sometimes get to some interesting stuff. But the point being left, right, left, right, left, right, analytic wisdom, emotional, relational, future-oriented, past-oriented. All right. Oh, here are some. Okay, I'm going to give you some. Here are some. Okay, good. You're hating me right at the bottom here. You're hating me right now. Okay, good. We started a little late, I guess, but I think I'm on track here. I think it's going to be okay. And please have questions for me at the end. Please have questions. So be thinking of your questions, please. And then we can call on you and stuff, or maybe put them in the chat if there is a chat, which I hope there is. You're hating me right now and thinking about killing yourself or breaking off treatment. But you and I both know that if you're ever going to understand why you have such trouble getting close to people, then someday you're going to have to slow down and give yourself a chance to figure out what keeps going wrong for you in your relationships. You'd been feeling so good about our work, understood in a way that you'd never before felt. And now you're feeling that I don't know you at all and that I don't care. But we both know that if I really didn't care about you, then I wouldn't have bothered to make myself available for this Sunday morning appointment. These are fun to say. You resonate first with their felt experience in the moment. And then that's anxiety assuaging support. And then you get named what they do, albeit reluctantly, know to be the reality of the situation. Here's some more. We know that you're in deep, deep pain right now and thinking about killing yourself to escape from the pain. And you can say it, you don't freak out. Like I don't freak out. It's like, oh my God, we got to do a suicide contract. You got to sign on the dotted line so that I can cover my ass if you kill yourself. I don't do that. I don't do that. I would tend to do more of these containing statements. We both know that you're in deep, deep pain right now and thinking about killing yourself to escape from the pain. And sort of like, yes, that is what they're feeling. You got it. I mean, you have to say what they are feeling. You can't just make it up. But you and I both know that were you to kill yourself, then your kids, whom you love dearly and would never want to hurt, your kids would never get over it and would never forgive you. They're like, oh my God, do we say stuff like that, people? Yeah, we do. You just can't get rid of this conviction that if you feel hurt by me, then you get to do anything you want, including breaking the rules, which you and I both know we need to have in order for our relationship to continue. And I would have a patient would come in sometimes and sort of sit on the floor in my office and want me to come down there too. And sort of like, I would say some of these containing statements and so on. And then sort of like, I don't think so. I understand you'd sort of like us both to be down there on the floor doing our therapy. But as you know, that's not the way we do this. And I've signaled many times in the past, that's not what we do. If we're really going to do this work and get serious about it, then we sit in our chairs and we do that. So they then reluctantly get up and so on. You just can't get rid of this idea that when you feel hurt by me, you're allowed to retaliate, even though you know that such behaviors are destructive to our relationship and to the bond that we have worked so hard to develop. I mean, they sort of do and don't know that, but they kind of know it. So I might be leading a witness a little bit, or maybe not. Who knows in that made-up situation. All right, now let's consider the scenario of a patient organized around borderline dynamics. So a patient who is continuously threatening suicide, yet equally insistent that she will never willingly go into a mental hospital. Does that put you in a bind? Absolutely not. The bind is not yours. The bind, or more accurately, the choice, belongs to the patient. You can therefore offer her the following suicide contract. It's a therapeutic intervention that contains, dignifies, and empowers. Okay. Oh, I just love this. You tell the patient that she is welcome, indeed encouraged, to speak of her despair, her hopelessness, her loneliness, her outraged disappointment, her fury at you for not understanding, for not appreciating how much she's suffering, for not making her better, and so on and so forth. You invite her, you encourage her. She's welcome to name and talk about all of that. But she is also to understand that from this point forward, if she ever says anything at all to you that sounds as if she might actually harm herself, then you will take that as her way of letting you know that she needs some form of external containment. In other words, if she gives any indication whatsoever, and you're the judge, you decide that she is even playing with the idea of hurting or killing herself, she is to understand, we do this in advance, she is to understand, you don't do it after the fact, she is to understand that you will take that as your cue to take action. And you will do so by insisting that before she can resume treatment with you, she must present herself to a psychiatric emergency room to be evaluated for suicidality. Your very clear message to the patient is this: if you talk about suicide or say anything at all that makes me think you might even be vaguely considering harming yourself in any way whatsoever, then I will understand that to be a signal for me that you're needing me to do something, that you are communicating a need for me to provide you with a clear, structured boundary to contain from the outside what feels uncontainable from within. If the patient then retorts, well, if that happens, I'll just tell the doctors at the hospital that I'm not really suicidal. Then you get to say, no problem. In any event, you will not be able to return to treatment with me until you've been evaluated for suicidality and basically cleared. Interestingly, and probably not surprisingly, patients usually test this non-negotiable limit only once, if even that often. And I have had to say that over the course of the decades, numbers of times to patients, and I mean it. Now, another situation, sorry, that happened was a patient who came to me, a very appealing patient, very appealing, and she was 37. And she said, I'd like to see you. So we had our session, whatever. And near the end, she said, I would like to see you. I really would. She said, but I do want to name that though I'm not going to do anything now, that I have resolved that at the age of 40, And some things were actually going to be happening at the age of 40. At the age of 40, I am going to kill myself. And I said, I mean, I didn't even flinch. I said, well, I said, I am so sorry. Um, I don't think I'm the therapist for you. I have plenty of colleagues who would be thrilled to work with you. And I've said some nice things about her, which was true. She was very engaging, insightful, authentic, wonderful. But I myself, I really kind of only want to work with patients who want to live. But I have colleagues who would be very, very whatever. Anyway, you can guess, especially since I'm telling you the story, as opposed to where she left and that's it. She did decide to stay and became, while working with me, ultimately all the way to like 48. And we did some beautiful work together. And she's still in touch with me. And we did some lovely work. I loved that. But we don't have to, we get to say stuff. Now, the other thing that I will suggest sometimes is in working with patients with borderline issues, we will end up saying stuff that we don't want to be observed from behind a one-way mirror. So we get to have the freedom to sort of say stuff. Or like my patient who came in and a relatively new patient, and she had already sort of slashed one arm and she had these ugly scars. They were really ugly. And I think it was after our first session or second session. And she had sort of slashed apparently her other arm, and she was wanting to roll up her sleeve and show it to me. And I said, oh, no, 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 no. I said, ugh, God, no, no. I said, and unless you want that arm to look like this arm, you better douse it with a lot of topical vitamin E. So, you heal it a little better. So it's not going to look like that. And she was a little bit stunned and horrified and angry, but like, whatever. I mean, I just like, whatever, I'm not interested in seeing it. So that kind of stuff just, again, I was carrying 30 borderlines at once, and you can't get like all worked up. Or one of them was so angry at me and so angry at me and in a rage. And so she said, I'm leaving. This was at the hospital at the Cambridge Health Alliance. She said, I'm leaving. And usually, I mean, I sort of pulled a fast one on her. Usually I would sort of fight to keep her, sort of like, oh, blah, 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 blah. But I didn't that time. I don't know. I was tired. I was whatever. I didn't. I just sort of sat there and just kind of didn't say much. And she left. And she went down to the emergency room, the psychiatric emergency room. My buddy Ralph was down there, and he talked to her, and he knew, we all knew her name, whatever, was a certain name, and everybody knew, all my colleagues knew that I worked with her, they knew. And so he called up me on the phone. He said, well, Martha, is down here, and she said that you told her you didn't want to work with her anymore. And I said, no, 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 send her back up. It's all good. So he sent her back up and she came back in. And, she was a little less tempted to sort of act out in that way again. She acted out in all sorts of other ways. But in other words, just not getting too worked up about that stuff. Again, think about if you have 30 of them, you just can't get all worked up. Now, I'm lucky. I've never had a patient suicide. I'm very lucky. Some of it is skill and a lot of it is luck. Okay. Okay, the therapist is not only providing containment, but also offering the patient an opportunity, to experience cause and effect firsthand. That if they do something, then you will respond in a certain way. Indeed, an essential part of mentalization is learning about consequences, coming to understand that provocative actions will have predictable outcomes. The therapist is emphasizing agency, central to cultivating the patient's awareness of how her behaviors are affecting both herself and those around her. So to reinforce this lesson, the therapist might offer a containing statement such as, although you might wish that you could keep talking about suicide and your desire to harm yourself, as you know, the reality is that if you do, I will take it seriously and will take the necessary steps to intervene, namely insisting that they be evaluated. Okay, here are a few more. Let's see. When someone lets you down as I have, your temptation is to flee. Though we both know that if you ever want to have a relationship, then someday you're going to have to stop running. so that you can figure out why you're so unforgiving, why you're so relentless, and what happens inside you when someone disappoints you. Like, and I enjoy saying that, and they do know that. And I mean, but I get it. When someone lets you down as I have, your temptation is to flee. That's exactly it. You're naming exactly. Though we both know that if you ever want to have a relationship, which you've said over and over again, you're dying to be able to have, then someday you're going to have to stop running. I mean, they don't love it that you said that, but they do know that. So that you can figure out why you're so unforgiving, why you're so relentless, and what happens inside you when someone disappoints you. When you're feeling this frustrated and angry, your first impulse is to lash out. But we both know that if you're ever to get better, then someday you'll need to learn to put into words how awful you feel instead of acting it out in such desperate, destructive, and indulgent ways. The goal is to create a delicate balance between empathic resonance and developmental demand. So between external holding through the empathic resonance and internal accountability that they really are, the consequences, they're responsible for things and so on, which they don't tend to think about. Okay, there's a picture. Here's one in the middle. When I keep letting you down like this, you wonder if you'll ever be able to trust me again. Though we both know that unless you're willing to do the work of trying to understand what happens for you when you don't get exactly what you want, then you'll never get any better. Okay. Integration statements. Okay, here we go. So that was to provide the containment. Now we're going to do integration statements. So it's a powerfully impactful intervention, particularly relevant for patients with a limited capacity to integrate the good and the bad aspects of their experience, my eyes on the time, and who, when overwhelmed by unbearable affect, regress to defensive splitting. So it can be masterfully employed or mistressfully employed in the aftermath of a therapeutic rupture. And it's most effective in those moments when the patient feels so devastated, so betrayed, and so enraged that she simply cannot remember ever having felt good about you, the therapist. So the therapist enters into the patient's internal experience of outraged devastation and comes to appreciate deeply from within that because the therapist has mentalizing capacity and comes to, I used to call that relational interoception, but I think I need to update that and call it mentalizing capacity. Anyway, the therapist comes to appreciate that the good of the past cannot, in these moments of rageful disappointment, be remembered or evoked by the patient, nor can hope for the future be imagined or envisioned. So here we go. Anyway, we're going to move on. It's a nice slide. It's in your slide deck, whatever. So here we go. They gently acknowledge, okay, it's an interesting something they do. The patient's difficulty holding good in mind in the face of present bad. Instead of saying, which we might be tempted to say, but just last week, you were saying that you felt good about me and our work together. But just last week, you were saying just yesterday, you were saying you've trusted me and you never felt this good this way before. You felt good about me and our work together. We don't say that. We do a subtle something different. More helpful to say, when you're feeling this angry at me, so we're resonating with and getting it that they're in a rage at you, it's hard to remember. We are resonating with their defensive forgetting, their defensive splitting and not remembering and not being able to evoke the memory of what had been or to imagine the good that could be. It's a subtle difference. We don't say, but just last week. We say, it's hard to remember that just last week you were saying that you felt good about me and our work together. Do you feel that? I hope you feel that. You're resonating with the defense. When you're feeling this bad, it's hard to remember, right? You're talking about the evocative memory capacity. You're saying you have a tenuous evocative memory capacity. It's hard for you to remember that you'd ever felt good and hard to imagine that you could ever feel good again. So again, you're not getting into a struggle with the patient where you say, but last week you were feeling good. And they say, yeah, but now I feel horrible. Sort of like about you. But I don't anymore. It's sort of like, well, it's hard to remember. You're calling your bluff a little, hard to remember, and yet you're getting said that you had felt good, and hard to imagine that you could ever feel good again. I mean, they're not really going to say you're lying. I mean, it's not lending yourself to to that. When your heart is breaking as it is now, you can't imagine that you could ever dare to trust again. When you're feeling this despairing, you can't remember ever having had any hope whatsoever. And in order to formulate these integration statements where you're trying to get adaptive integration instead of the defensive splitting and helping them to develop evocative memory, it feels really good to get these things said because you feel it. You can feel it. And I found with one of my patients actually that concept of that when you look up to the left, you're accessing your right brain. And when you look up and to the right, you're sort of accessing the analytic wisdom in your left brain. And sometimes she will, in order to access both, she'll sort of duh. And so in a way, we're kind of doing EMDR on ourselves. We can do that. All right. Integration statements do not correct the bad. Rather, they make space for what cannot yet really be held. Okay. Yeah. Okay, this is just sort of saying again what I'm saying. The integration statements do not boldly counter the bad with an in-your-face declaration of past or future goodness. Instead, they attune sensitively to the patient's current distress while softly, strategically nudging her toward remembering past good and imagining future good. And again, you're ever busy feeling your way into, I guess, mentalizing, or what I would have called relational interoception, what your sense is of how anxious they're being made by what you say. And one of the things that I find myself saying when in the spot supervisions, which anybody can join, by the way, they're entirely free, both live and recorded, if I could be so bold, is like for the importance of working with the patient's anxiety and not just all nicey nice and sort of easing it and supporting them and so on, but creating optimally stressful growth incentivizing mismatch experiences, which by the way, the containing statements do, and this in a slightly different way, integration statements do as well. In the moment when you're feeling this angry, that's resonating empathically, it's hard to remember, you say it kind of, you resonate with that defense, that you'd ever felt good about me. That's sort of like going to make them feel a little anxious. So what I'll say sometimes is, so when a case is being presented, I'll say to the presenter, and there have been some fabulous cases presented, but I'll say to the therapist presenting, I'll say, have you ever offered created optimal stress for the patient, made them sort of more anxious? And so what will happen sometimes is the case presenter will say, well, yes, I think so. And then they'll tell me an absolutely brilliant interpretation that they had made, that they shared with the patient. Just brilliant. So like ties everything together. And so I say, how did the patient respond to that? And they say, oh, the patient loved it. Well, then it's a brilliant interpretation, but it's not optimally stressful. And if we want deep embodied change, second order change, and really to sort of get there with stuff like we need to do a little optimally stressing of them and being attuned to their level of their anxiety and kind of finessing things and increasing it, decreasing it, increasing it, decreasing it, and attuning to that and so on. And I think that a lot of the folks, classical psychoanalysts, are probably not as adept at sort of thinking along those lines. But a lot of the short-term intensive psychodynamic folks use the patient's anxiety and defensive reactions in a brilliant way, in the way that Habib Davanloo had done. It's just brilliant. It's mind-bogglingly brilliant. All right, these interventions. Okay, delicately introducing anxiety-provoking challenge. I think you get the idea. I want to move on here. They're good things, and you have these in the slides. Oh my God, enough already. All right. Okay, now mentalization statements. All right. To nurture the patient's capacity to mentalize, most relevant for patients struggling with borderline vulnerability and fragile capacity, although ultimately applicable across all diagnostic categories. Another two-part intervention, I call it a mentalization statement. And I'm eager for input from you guys about these. I've worked really hard on these. These statements invite the patient to, this is often said about mentalizing, think about thinking, wonder about wondering, and holding mind in mind is the way they describe it. Those aren't mine, but it's described that way. More specifically, these statements sensitively support the patient's emergent efforts to make sense of and cultivate reflective awareness. Those are two critical words for mentalizing. Reflective. Representational awareness also works, mentalizing capacity, but reflective awareness about the underlying mental states of both self and others, even as these mentalizing statements that I've created, even as they respectfully acknowledge inevitable moments of confusion, uncertainty, and not knowing. All right, so let me try to offer you a few. So, all right, so Fonagy talks about self-internal focus and other external focus. So I had to have two different kinds of mentalizing statements. All right, so here we go. You know it's important. This is a self-internal focus. You know it's important that you try to make sense of the X that you're thinking, feeling, or doing. Now, what's that going to do to their anxiety? Increase it. You know it's important that you try to make sense of, oh, you're saying it nicely. You try to make sense of the that you're thinking, feeling, or doing, and how it might be impacting others. Now you resonate with their experience of like, oh, overwhelming, confusing, not sure, uncertainty. But right now, it just feels too confusing. But you've named, you got a lot done that you know, two of my favorite words, you know, it's important that you try to make meaning of, make sense of the whatever that you're thinking, feeling, and or doing, and how it might be impacting others. But right now, in the moment, this is all present moment, it just feels too confusing. Other external focus, very similar. You know it's important that you try to make sense of the X that the other person might be thinking, feeling, or doing, and how it might be impacting you. But right now, it just feels too confusing. So these are my best efforts. I'm going to do these quickly and then move on. My eye is on the time here. You're highlighting the interplay of cognition, experience, and behavior. All right. You know it's important that you notice how conflicted you feel. But at the moment, it feels almost impossible to stay with that tension. You know it's important that you pay attention to what thoughts keep coming up. But at the moment, you feel confused. They feel confusing and overwhelming. You know it's important that you be aware of the tension inside you. But at the moment, it feels hard even to locate what that tension lives, where that tension lives. You know it's important that you observe your feelings as they arise, but at the moment they feel tangled and difficult to sort out. Do you see what I'm trying to create there? Again, I'm very open to feedback. Now, other external mentalization statements. You know it's important that you notice how the other person's words are affecting you, but at the moment it feels impossible to sort out your own reactions from theirs. A few more. Third one, you know it's important that you be aware of what their behavior triggers in you, but at the moment you're just not sure. So I want to be sort of juxtaposing, let's see if I say this, yeah, is stretch without overwhelming. The therapist is gently challenging the patient, thereby increasing the anxiety, to notice, to name, to wonder about mental states, but is then softening that challenge with empathic validation of understandable, inevitable confusion, thereby creating optimal stress, enough to foster growth, but not so much as to shut it down. That's ideally. All right. Okay. Mentalization statements gently invite the emergence of reflective awareness while mirroring the patient's struggle to get there. Now, I just had to throw in this slide, which people have said they like. It's my rule of three. I have no idea why I called it the rule of three, but I call it the rule of three. And it's along these lines of mentalizing. And it's really useful in Model 3, the intersubjective perspective, but it's very useful, period. It's particularly useful for patients with borderline tendencies, especially when they're engaging in, excuse me, a provocative enactment. So it can be used to invite or compel the patient to take ownership of what she is enacting on the stage of the treatment. To that end, the therapist might ask any or all of the following three questions. And I really hope that you'll sort of get this. People have told me that, the next day they can use this in their sessions. How are you hoping that I will respond? You can ask any one, two, or three of the following. How are you hoping that I will respond? Which speaks to the id. How are you fearing that I might respond? When they've done a provocative enactment, you think they've done something that's provocative and you feel provoked and you're not quite sure, countertransferential, like, oh my God, I'm feeling pretty angry. I'm feeling a little bit put off. I'm feeling sort of confused. And so then you put back onto them and have them put words to their actions, right? Mentalize. How are you hoping that I'll respond? That's it. How are you fearing that I might respond? That's superego. How do you imagine that I will respond? Which speaks to the executive functioning of the ego. All three questions insist that the patient put language to her interpersonal intentions, thereby guiding her from implicit action to explicit mentalization, and from reflexive, procedural, had to put that in there, procedural knowledge, unformulated experience, Donald Stern and some of the others, enacted knowing, to reflective, declarative, formulated, mentalized knowing. That's what we want. From enacted knowing to mentalized knowing. And, in partners and couples, and when they're fighting, or with a parent or with a child, good for there to be being mentalization and awareness of, instead of just sort of like playing the stuff out, to be aware of and to make meaning of and to have a sense of, observe and reflect upon and make meaning of the dynamic that's going on between two people, what you're feeling, what they're feeling, and how that then impacts your behavior and your actions and so on. This journey from enactment to reflective awareness fosters accountability, empowers the patient, and expands the capacity for mentalization. All right, thank you folks for staying with me, but now here we go. This is the something different that we're doing with our patients. We're going to offer them a new kind of experience. All right, so just to review, the therapist draws upon these three optimally stressful two-part growth incentivizing interventions. Containing statements, you're feeling terrible right now, cursing the day you ever met me, and convinced that you can never trust me again. Remember that? Resonate with their experience in the moment, empathic resonance. But we both know, right? We both know, or but we both know that surviving these crises is part of our work. We've done it before and we'll do it again. Nobody said it would be easy. So here we're insistence upon relational accountability. Those are containing statements. We do a lot of them. Integration statements. When you're feeling this enraged, right? Nice empathically resonating with. It's hard to remember, also empathic, that you had ever felt good about me in our work together. That makes them anxious. And equally hard to imagine that you could ever feel good about us again. So they're juxtaposing empathic resonance with invitation, to awareness of their difficulty evoking. And finally, mentalization statements. You know it's important to try to figure out what's going on inside you that's making you feel so enraged and causing you to do things you later regret. But it all feels so overwhelming right now that it's hard even to think about what might be provoking your anger. And there we are, there's a gentle challenge with empathic cushioning. So you're doing a lot of those. Okay. It is the therapist's provision of external containment that makes it possible for the relationship to continue. You need to have the patient in the treatment or you can't do it, despite the frequent storms and crises. Whenever the patient is disappointed, frustrated, or thwarted in her desire, the therapist must meet the patient's aggression and survive the patient's repeated attempts to destroy the relationship and the therapist. Again and again, the therapist proves her indestructibility. In surviving the patient's attempts to destroy her, the therapist is offering the patient something she has never before experienced, namely, the experience of steadfast containment. The therapist doesn't flee, and the therapist says stuff that over and over and over again that helps the patient not to flee. Not that every now and then she might, but then she does come back. My patient flies out of the room down to the emergency room, and Ralph sends her back up. All right. Indeed, when the therapist can meet the patient's urgent need to have her impulsive, rageful, and destructive behaviors limited and contained from the outside, because the patient lacks the internal capacity to be self-containing. So we got to provide it from the outside, known more familiarly as providing firm, non-punitive limits. The patient will gain a new kind of experience, the powerfully transformative experience of having intense affect, including murderous rage, debilitating anxiety, and suicidal despair without devastating consequence. And you still have the patient in the treatment. In moments of devastating disillusionment, the patient with borderline defenses, lacking the internal structure to weather the crisis, she lacks it, loses hold of all that had once been good. We know that. In the grip of her unmodulated, dysregulated rage, she's drawn toward retaliation, even if it means destroying the very relationship she has come to treasure. But the therapist's willingness and ability to meet the patient's aggression, the therapist's unwavering steadfastness in the face of it, the therapist's consistent provision of external containment of the patient's destructive acting out, will enable the relationship not only to survive, but to endure and evolve. This is just to keep the patient in the treatment for now. Survival here means the ever-evolving capacity of the relationship to withstand the frequent storms and inevitable crises that once would have torn the relational fabric apart. The patient would have fled or lashed back in such a horrible way that often, therapists do often get rid of patients who are too much into borderline enacting. But the therapist refuses to allow the patient to destroy the relationship, just as she refuses to allow herself to be abused. One of the sentences that I really don't like when therapists say is, "I'm not going to let you abuse me." It's sort of like, well, don't let the patient abuse you, but don't just say, "I'm not going to let you abuse me." Don't let them abuse it. Push back, show indestructibility. I know that right now you're hating my guts. You'd like to get rid of me, and you feel that it'll do anything, but you and I both know that. So that's where a good containing statement could work. Indeed, if the patient is gently yet firmly anchored in the relationship by a therapist who steadfastly refuses to collude with the patient's impulse to destroy or to flee, and is instead offered a protective space within which she can give voice to her anguish, her panic, her desperation, and her outrage, her wish to escape, to lash out, to retaliate, even to destroy. And quite frankly, the therapist can handle that. The therapist is sort of like, whatever. I used to think about it as thinking of there being just lots of walls between you and the patient when they're in this kind of rage. For you not to be just like, and really countertransferentially just really impacted by it, just really to get it, decenter from your own thing, enter into their experience and get it, that they are just fighting for their life on some level. They're in so much pain. So instead, though, and you're offering them a protected space, within which she can give voice to all of what she's feeling. Then in time, she might be able to reclaim the good feelings she had once known. Not because the rage has been silenced, but because it has been welcomed into language, mentalization. Thank you, Peter Fonagy. Met with empathy and understanding, held within the therapist's emotional robustness, and allowed to run its true course, without judgment, without retaliation, without collapse. Held, named, and understood. not enacted. Perhaps days, maybe weeks, sometimes even months. But with each exchange, with each cycle, the patient moves closer to reclaiming the good that was lost, step by step, within the calm, steady hold of the relationship with a therapist who proves her indestructibility. She's not to be daunted. And that's why sort of the patient, not that this is a huge one, but the patient wanting me to go down on the floor with her, sort of like, I don't think so. No, you and I both know. Oh, we don't do that in here. Or the patient's walking around the room and this and that, and sort of like, as you know, I know you're angry right now and wanting to make sure that I know how angry you are. But as we both know, we don't really start the session until you figure out whatever you need to do to come over and sit down so we can talk. So you're not like freaked out, like, oh my God, and sort of like, oh, I don't know, I should refer you to somebody else. I mean, we're just sort of like, all right. Okay, here we go. In time, we're getting nearer the end here. In time, the patient begins to recover her good feelings. The disappointment is survived, and the relationship, at least for the moment, endures. For the moment, there was a disruption, but you keep the patient in the treatment with containing statements, integration statements, mentalization statements, and though they're tempted to act in all sorts of destructive, bad ways, and or to flee, at least they're still there. It may take months, days, weeks, whatever, but eventually the storm calms down. You're still there, they're still there. And they begin to recover their good feelings. The therapist can then introduce something that I refer to as an inverted integration statement, not to get you totally confused. But these interventions are used not when the patient is feeling bad, but in those moments when hope has returned and the patient is truly feeling good. An inverted integration statement underlines the fact that when the patient is truly feeling good, it can become difficult to recall the bad that had come before because she's still got the defenses splitting. When you're feeling this good, it's hard to remember that you had ever had doubts about me and our work together. When you're feeling hopeful as you are now, you find yourself wanting to forget about the times when you were filled with despair, rage, and deep uncertainty. In essence, the therapist maintaining her own perspective throughout, both the lows and the highs of the therapeutic engagement, is simply reminding the patient that this too shall pass. Not because the therapist is a Debbie Downer, but because she seeks to highlight the continuity of the patient's internal experience, the continuity of the patient's being, the thread connecting past, present, and future. In this way, the therapist is attempting to integrate both the good and the bad, another way, to integrate the good and the bad in the patient's experience of self and others. In addition to containing, and mentalization statements, then the therapist makes liberal use of these integration statements and inverted integration statements. All right. Now, the alternation between bad followed by good, disruption followed by repair, and good, all is well, it's all good, followed by empathic failure, frustration giving way to gratification, gratification giving way to frustration, becomes a recursive, integrative rhythm within the patient's evolving, lived experience of the therapy and the therapist. This ongoing oscillation between rupture and repair, between satisfaction and disappointment, establishes a deep emotional cadence, an ever-expanding flow within the relational field. Patient and therapist continually meeting at their, Darlene Ehrenberg's, intimate edge and navigating the delicate interplay of vulnerability and strength on the parts of both. In so doing, they are gradually cultivating a foundation of mutual trust and deepened understanding. I mean, it's really interesting. I mean, when you've sort of been through the wars together and survived, you both survived, you both survive. It's sort of an incredible experience. The integrative process, the dynamic synergy of containment, integration, and mentalization unfolds as follows. The patient experiences disappointment, struggles to tolerate it, and feels sorely tempted to act out. And we're getting near the end here, in impulsive, rageful, indulgent, or destructive ways. But the stalwart therapist reliable and unwavering, provides external containment in the form of containing statements, fosters adaptive integration of good and bad by means of integration statements and inverted integration statements, and cultivates reflective awareness, facilitated by mentalization statements and the rule of three, all of which deter the patient's proneness to defensive splitting and unreflective enacting in the face of emotional overwhelm. The therapist repeatedly demonstrates her reliability, consistency, and faith in the durability of the patient and of their connection. This allows, and I've had patients who write me a little note and they will say, "Thank you for bearing with me." They don't always necessarily get that said in the session, but I've had numbers of patients over the years. "Thank you for bearing with me." Again, they don't say that to your face, but they say that. They let you know that. The therapist repeatedly demonstrating her reliability, consistency, and faith in the durability of the patient and their connection. Here's another example. A patient with whom I was working had some borderline tendencies for sure. The way we'd set it up is we met once a week, but if either one of us sort of felt that we wanted an extra session that week, that we could and should, because she would have periodic crises, et cetera, then usually it was I. But I would say, are we thinking maybe an extra session this week? And the patient actually paid less for the extra session. I'd sort of set it up that way. And so on. So, and periodically over the course of the days, weeks, months, at the end of a session, I might say, maybe this week, maybe we put in that extra session then on Friday. And the patient would inevitably say yes. All right, well, we had a session that was just, it was a bloodbath. I mean, it was, and the patient was just blasting me and hating my guts. And I've never this, and you're incompetent, and you're inappropriate, and you're this, and I hate your guts, and I don't even know why, blah, 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 and so on. And I mean, it was very, very, very that way. And I remember this as if it were yesterday. And I remember sort of gathering together my strength and saying to her, "Do you think maybe," I mean, she was saying, "I don't ever want to see you again. I hate your guts. I don't even know if I want to continue." I said, "Do you think it's maybe this," I had to stutter because I was so kind of trouble saying it. "This would be a week where we have that Friday session?" She looked at me and she said, "God, now." Anyway. So we didn't have that session. She did come back the next week, and she came back many, many more weeks, months, years, whatever. And there came a time when she said to me, "Thank you for offering me that extra session. So even though I shot you down, and hell no, that you had faith in us and in our relationship, even though I was blasting you. Thank you for that." All right, so the therapist demonstrates that. This allows the relationship to endure, the storm to be weathered, and the patient's good feelings to be restored. The cycle repeats itself again and again. The patient's inner lived experience, I didn't say internalize, I didn't. Adaptive internalization of self-object, whatever. That's not the focus here. No, with patients with borderline stuff. It's the patient's lived inner experience of storm, stillness, crisis, resolution, rupture, repair, loss, recovery, disappointment, relief, bad, good. This oscillation progresses at an ever-accelerating pace, with the recovery time after each destabilizing disillusionment growing shorter and shorter. In essence, the patient discovers that she can, time and again, survive the vacillation between the bad and the good, between devastating lows and exhilarating highs. And in turn, the therapeutic relationship itself grows increasingly resilient, strengthening precisely at the broken places. The patient is beginning to experience in a deeply embodied fashion the coalescing impact of this rhythmic, cyclical dance of being in relationship with someone who remains steady, reliable, durable, committed, and emotionally invested, who stays empathically attuned even amid repeated ruptures, refusing to withdraw, retaliate, or give up. And so, perhaps for the first time, the patient finds herself beginning to believe that she can weather storms, endure disappointments, and even embrace the possibility of a new beginning. Having survived the storms and crises, I'm almost at the end here, of periodic disillusionment, the patient gradually evolves from pre-ambivalence to ambivalence, from defensive splitting to adaptive integration, from a fragmented self to a cohesive self, from fragile to robust evocative memory, from pre-reflective enactment to reflective awareness, from impaired grieving to evolved capacity to grieve, from emotional storms to embodied stability, from relentless hope for perfect external care to acceptance of the good enough, the approximately perfect, from defensive need for perfection to satisfaction with the good enough, the approximately perfect, from inner chaos and anguished turmoil to embodied presence and emotional resilience. Final reflections. With respect to the development of evocative memory capacity in patients who revert to borderline defenses under emotional overwhelm, it will not, therefore, be the patient's experience of grieving disillusionment. I was not talking about grieving specifically. I mean, there was raging about stuff and there was this, that, whatever, and tears as part of whatever, but not specifically grieving disillusionment with an idealized self-object therapist and optimal frustration, growth incentivizing optimal frustration that will make the difference, which is what happens with patients in Model 2. Rather, transformative will be the experience, the lived experience of being held in relationship by a containing self-object therapist, optimal gratification, who proves herself indestructible, refusing to be daunted by the patient's disillusionment, outrage, or impulsive rageful enactments. In other words, it will be the therapist's consistent provision of gratification of the patient's need for containment that will prompt ultimately the development of evocative memory capacity and in turn the patient and then the patient's capacity to grieve. But they have the evocative memory capacity such that they can then grieve and they can do all that stuff that patients in Model 2 do. In essence, transformation of the, I have one more slide after this, transformation of the relentless search for external perfection into self-sustaining resilience and the internal acceptance of good enough will be the felicitous outcome. It may take years, by the way, and I'm going to give you a little case in my next slide. It took 8 years. Will be the felicitous outcome, not of grieving optimal failure, but of experiencing optimal containment. Ultimately, resilient self-support, the adaptive capacity to be a good enough caregiver unto oneself, self-soothing, will become the antidote to the relentless pursuit of idealized external caregiving and perfect attunement. The hard-earned ability to be deeply satisfied with being the source of one's own sustenance, which is also what we want to have happen in Model 2 as well, for patients with narcissistic issues and self-deficits and impaired capacity to be a good parent unto themselves, a good caregiver. So the hard-earned ability to be deeply satisfied with being the source of one's own sustenance and the good enough attunement that real life provides is the hallmark of successful transformation, from relentless hope to realistic hope, the sober, mature acceptance that storms can be weathered, disappointment survived, and a new beginning embraced. Now for my last slide. Oh, that isn't my last slide. There's one more after this. From relentless hope for external provision of perfect caregiving to self-sustaining resilience and internal acceptance of the good enough. Here's the slide. I'm reminded of a beloved patient of mine who entered treatment with a diagnosis of BPD, a trail of failed therapies behind her, and a series of exhausted, defeated, and enraged therapists in her wake. But after 8 years of intensive psychodynamic work with me, through many battles, repeated efforts to take me down, and begrudged grieving along the way, as she came to terms with previously unbearable truths. She was no longer a borderline. Her parting words as we terminated still resonate. You're the kind of person who would kick the crutches out from underneath a cripple. Thank you. I still chuckle, obviously, I'm still moved as I remember. She stayed in touch with me over the years, much to my delight, and is clearly doing very well. All right, well, I think that's it. There, thank you. Email me if you want to be in my spot supervision groups, and they're free, and then a lot of references. There you go. And I'm going to, there you go. Oh, look at that. Oh, thank you, Grace. Oh, now I can see everybody. Oh, thank you, Giselle. Oh, look at that. Oh, these are my people. Oh, thank you. Oh, there's Jean Whitehouse. Oh, this is sort of wonderful for me. Oh, oh my goodness. All right. And I happen to know, wait a minute, I believe that, let me get this right. Pasuka Loke, you are Sharon's classmate. I think that's right. Anyway, oh, there's Mark. Good. There, yeah, Sharon, and Boriana. Oh, a lot of my friends here. Oh, from Jay Francisco. Oh, this is so good. All right, now this is where you're supposed to. Oh, we do have comments in the chat. Oh, good. I'm going to read them. I'm going to read them, I think, unless Bill wants me to do something else.
No. Well, no, you can read them, but first I want to say thank you very much. And unmute yourselves on in America and over here. Unmute yourself, put your hands together, and show appreciation. I have to every time I hear you, I'm reminded of the fact that you're the Rembrandt, the artist,
Oh,
the divine artist of interventions. Nobody gives interventions like you're capable of giving that I
oh,
know of. So
oh,
thank you very much for that. And
oh,
for being with us and for being part of our adjunct faculty. Now,
oh.
if you want to read the comments, so that we haven't kept a list here of questions or comments, so you'll have to read them.
Oh, that's okay. Oh, that's all good. Thank you. Thank you. And let me just say, I mean, all of you here, some of you practically in the middle of the night, some of you 3 hours earlier than me, some of you in the Philippines. It's just wonderful to see you. Look at this, these names that I see and don't always see in person. Lady Appel. Let me just go to my next page. I'm sorry, real quick. Like I'll do this real quick. Like Mita, some very familiar names and faces. Oh my God, Christine, thank you. Okay, good, very nice. Thank you so much. You indulged me in that. Oh my goodness. Okay, there you go. All right, so we're going to do these things here. All right, the Lauren Corbett. These mentalization statements. Oh, are awesome, Martha. You're encouraging the patient to be curious about their experience. Yeah. Yeah, that's right. Okay, good. Thank you. Thank you. I guess that is right. We get yes from Jeffrey. Thank you, Jeffrey. And Grace. I saw who Grace was too, and I think I saw Jeffrey. Okay, Boriana. I was so focused on evocative memory capacity. Oh, but now mentalization and the statements are really crisp and getting more deeply integrated into my understanding. Thank you, Dr. Stark. Oh my goodness, I didn't realize I was going to get so many wonderful comments here. Sharon, whom I've just adored for years now, and she's such a brilliant musician and a brilliant soul. Okay. Steadfast containment by the therapist is profound, Martha. Thank you. Yeah. 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 I'll tell you an example of where there wasn't steadfast containment. Um, one of my supervisees was talking about her work with her therapist and so on. It was just telling me about it a little bit and said, I really need to be winding up my work with my therapist. But my fear is that I'll say it nicely, but that if I let her know that I'm thinking that I want to be kind of wrapping things up, my fear is that she won't handle it very well. And I said, Oh, I mean, I think, I mean, you do it carefully, do it thoughtfully, but I would think that, yeah, go for it. Anyway, so my supervisee came back the next week, said, well, Martha, I appreciated your encouragement, but actually I said what I did to my therapist. And she burst into tears. I got that one wrong. Anyway, I don't know. Maybe the patient would have to stay with the therapist forever. I don't know. But anyway, so we really we need to be, and sometimes with borderlines, what I will do, sorry, I called them borderlines. I know I want to be more respectful and say patients with borderline features. We used to call them borderlines, and you know, borderlines. But anyway, but we in working with such patients, there are times when we really, one of the things I most often say to my the patients and to my supervisees is when people are busy personalizing things and sort of like they feel hurt or they feel injured or they feel this or that, when really, quite frankly, it's primarily a story about the other person, and yet they've internalized and personalized it and feel that it's sort of about them. Whereas you want to just sort of keep in mind that it's a little bit about you maybe, but a lot about them. So that to protect you from just it going in and then you start crying when your patient says, I'm thinking to be wrapping up, and so on. Anyway. All right. Well, thank you, Sharon. I appreciate that and your smile there. Oh, good. All right. Jeffrey. Oh, good. I struggle. Oh. Thank you, Jeffrey. I struggle with self-esteem and mentalization. Oh, statements work for me. Oh, wow. Knowing what to say and do helps. Oh, good. Oh, good. Oh, good. Thank you, Jeffrey. And I'm sorry that I pointed out that you weren't muted, but I appreciate your support here. I really do, Jeffrey. So bless you. And mentalization statements work for me. Yeah, they work for me too. I mean, mentalization statements, just sort of thinking about what's me, what's them, what did I do perhaps that elicited that reaction from them? I'm not a complete victim here, but I did something. But what were they? But then I was reacting to them. I mean, it's Model 3 stuff, zeroing in on nothing. Everything is co-created. Nothing is just sort of like, well, they did it, or I. It's all co-created, a reaction to what's going on in the intersubjective space. Well, thank you, Jeffrey. I appreciate that. Knowing what to say and do helps, and actually, Grace likes that. Sharon's, we got some stars. Thank you. And Jay said, thank you. Giselle said, thank you. And thank you, Giselle. And hello, Max. Thank you, Martha. This has been immeasurably stimulating and offering a sense of new possibility. I regret I must hop off right at 7 tonight. Thank you, thank you, thank you. All right, Mona, hello, Mona. I love the 3 statements. Okay, good. I always learn so much, and Dr. Stark's enthusiasm is contagious. I feel so lucky and grateful to be here. Thank you. You know, and I feel very grateful that I am so excited about this stuff. I mean, I don't even know why I am exactly, but I just am. And I mean, I used to offer presentation, you know, I like read, you know, we used to do that at the Boston Psychoanalytic, you know, we get our papers and we read, and so at that, and so and that, And then about 10 or 15 years ago, I started doing more in the way of PowerPoints, because in the integrative medicine world where I lecture sometimes, I mean, if I read a paper in the integrative medicine world, I mean, I'd be kicked off the stage. Everybody uses PowerPoints. And so I started doing PowerPoints, and I just love creating PowerPoints. I just do. I don't know why, I just do. And I work it and I just kind of do it until I get it right. And that first slide, oh my God, that I spent 50 hours doing, I do love that slide. Sometimes I pop out of bed in the middle of the night and I get up and I do some more revisions to my slides. All right, anyway, moving on. You love the 3. Thank you, Mona. Oh, and thank you. I said that. Judy Pillinger. Many, many thanks. So sorry to have to sign off during the chat. I know I'm kind of, although we did start a little late. So appreciate your brilliance, Martha. Thank you, Judy. And Lauren Corbett. Such clarity here, passionately presented with deep appreciation. Thank you. Gosh, I didn't realize I was just reading all this wonderful stuff, but thank you. Sometime please speak more. Oh, about Model 5. Yeah. Quantum disentanglement. Yeah. So, I mean, not to be pushy or anything, but I do whole lectures on Model 5. And one of my lectures, oh, my YouTube, I have a YouTube channel. I'm allowed to say that, right? YouTube. And I think the handle, is that what I say? The handle is the Stark method. And I have one up there, for example, memory is a verb, not a noun, colon. The healing power of therapeutic memory reconsolidation. So model 5, it was I came to lately. Model 1, the classical psychoanalytic, I developed that because I was learning about that at the Boston Psychoanalytic during the 1970s. Then in the 1980s, I was exposed to all the self-psychological stuff. So I had to create a model for that. And then in the 90s, all the relational stuff. So I go, oh my God, I got to include that. So that was in the 90s. So models 1, 2, and 3 in my award-winning Modes of Therapeutic Action book, which was published in 2000. Actually, it's 1999. 1999, I want to say that. And in 10 years, the copyright reverts to me. Just saying that. 1999, just saying that. I don't know if some of you appreciate the significance of 35 years, whatever, and then the copyright comes back to you, and then you have the freedom to do stuff like give the book away for free. But anyway, and then from 2000 to 2010, I got exposed to all the existential humanistic stuff, and I had to add that. And that's also where I say my buddy Larry Hedges, who knew my work well enough to know what was missing, he said, well, model 1, structural conflict, model 2, structural deficit, model 3, relational conflict. Thank you, Stephen Mitchell. Model 4 has to be relational deficit. You got to do that. I said, no, I want to be rigid here. No, I'll keep my models 1, 2, 3. He said, no, you have to do relational deficit. So finally I decided, okay, what the hell, I guess I'll do relational deficit. And of course, now the model is so much better as a result. And I feel I have to go back and apologize to all my patients who, when I wasn't fully aware of my model 4. All right, that brings us to model 5. So from 2010 to 2020, was when I sort of got a little clearer about that these short-term intensive folks, the ISTDP, all the alphabet soup, ISTDP, AEDP, IFS, EFT, hypnotherapy, SE, somatic experiencing, psychomotor psychotherapy, PBSP, whatever, EMDR, that they do stuff. They do stuff in a way that's like focused and intensive and laser focused, not as broad based as the more psychoanalytically informed models 1, 2, 3, and 4, but they zero in and sort of like, shit, man, to be with the program here, I better do my model 5. And so that became the quantum neuroscientific one. So again, yeah, you're juxtaposing in an embodied way the patient's experience of old bad and juxtaposing that with their envisioning of new good, something new, compellingly better, different. And you juxtapose to create mismatch experiences and back and forth, back and forth, back and forth. And you co-create, patient and therapist together, co-create these quantum disentanglement statements. It's the only time when patient and therapist work together to co-create statements. And it's very powerful. And you write them down and then we read them and we talk to each other and we say it. It's very powerful. But you have to be able to envision new good as a counter to old bad. So let me just say, what I came to realize, the importance of juxtaposing old, bad, new good, is that sometimes more classically trained psychoanalytic folks are sort of all about remembering and reliving and re-experiencing old bad, and then remembering, reliving, and re-experiencing old bad. And as Donald Hebb had said back in the 1940s, neurons that fire together wire together. So on some level, potentially the problem with continuing to revisit old bad is that it gets reinforced unless you offer a viable antidote. Now, by the same token, there are treatments that are like positive psychology. When done in certain ways, is sort of like new good, new good, new good. Well, what about old bad? That's still there. New good, new good. So model 5, Cito is nodding on that one. Learning from the ISTDP, AEDP, and all them their folks, it's sort of like juxtapose old bad, new good, old bad, new good, old bad, new good. And sort of like that's the way you can therapeutic memory reconsolidation, and you sort of open up you deconsolidate and create a window of opportunity where if you introduce something new and good in those moments, then you can temporarily, you can work to sort of supersede the old bad, and you do it over and over again. And I remember when I was so excited about this, talking to one of my supervisees who is a hypnotherapist. And I said, wow, this is so cool. And he looked at me and said, oh, Martha, he said, you know, we hypnotherapists, we've been doing this forever. Sort of, oh my God, who knew? Anyway, and I think it's relevant for all of the models, quite frankly. Anyway, I didn't really answer the question, Joyce, but you'll just have to go to my handle, The Stark Method, on YouTube and listen to the memory is a verb, not a noun. Okay, good. Christine Itmus, is it meaningful to use containment? Oh, yes, it is. Yes, it is. Containment rather than holding. Yes, it is. Thank you for letting me say that. The word seems more inclusive of the dysregulation. Oh, yes, and you're saying you're helping me you're acknowledging that indeed, yeah, holding is kind of more nicey nice, and you know, empathic attunement and all the good stuff. It's all good. Containment is, yes, thank you, Christine. That's right. I had not emphasized that, but that's right. It's more inclusive of the dysregulation. Yes, it is. The containment, the structure, the containment. And and doing it, admittedly, I was saying you juxtapose empathic attunement with, you know, a little more sort of challenge. But yeah, there is more sort of holding is just more nicey nice. I'm sorry, holding is much more than just nicey nice. But yeah, so thank you, Christine. That's brilliant. That's beautiful. Yeah, it is more about containing their dysregulation so that they're not going to be busy fleeing. Cito, oh good, because I saw you earlier nodding there. Therapists need therapy. Oh yeah. When handling difficult patients. Yeah. And we need supervision. And may we either have a supervisor or supervision group. I have a supervision group. Somebody I mean, it's now just one person, quite frankly, but somebody I've been working with for decades. And they know me so well, I know them so well, I can just say anything. And yes, important, good if we can have been in our own therapy and it to be being a good one. And for us to have experienced optimal stress and how that can then bring about, you know, so it's not all just easy. I have a presentation I do called The Holding and the Provocation. So the holding and then the introduction of the provocation. So homeostatic attunement and then introduction of disruptive attunement. But yes, thank you, Cito, to mention that. This training session has been, therapeutic for me. Oh, thank you, Cito. Oh, I really appreciate that. Thank you very much, Dr. Stark. Oh, Philip Plattner. Nice to hear you speak once again about ways of engaging patients in an effort to help them live their lives more fully. Yeah. You know, and some of it has to do with and here Bill Kerwan and I understand the concept of, you know, as we're getting older. I mean, Bill, I'm not telling tales out of school here, right? I mean, you know, as we get older and the runway in front of us gets ever shorter, and yet we just love what we do, and we're not going to stop because we're just not. But anyway, and I know that I've developed a more better a perspective on things, and I am getting ready. I think I'm getting a little more ready for my Model 6, and my Model 6 is going to be somatic spiritual, and I get a decade to do each one of my models, and I'm not evolved enough yet to do my somatic. I kind of got the somatic stuff, but the spiritual. But it's going to be from, it's going to be from disrupted flow of information and energy throughout the system to accelerated flow, because we go from restricted flow. We go from, restricted flow. We go from R words that are defenses to A words that are adaptations. Anyway, I'm speaking out of line here because I haven't done it yet. No, it's not ready yet. No, it's not going to be ready for another 5 years. Okay, there you go. All right, nice to hear. Oh, good. Thank you, Philip Plattner. Suzanne Kerr, thank you, Martha. Oh, from the bottom of your heart. Oh, and Cheris Felix, thank you all for this brilliant and beautifully put together lecture, Dr. Stark. Oh, thank you. I mean, I've lived this lecture. I wanted to do it for my dear Bill, and Midge, and for all of you. And I did, and I'm glad you had the PDFs. You'll notice they're a little different from the way because I changed them a little bit in the last day, but they're close enough together. This is a great expansion addition to what you have shared with us from the previous lecture you gave us here at AGST. Your first lecture for us was very effective when I applied it in my sessions, and I'm excited to also apply the new statements I learned today. Oh, good. Thank you. Thank you. Okay, that is it. Well, listen, we did good here. Thank you for letting me run over. I know for
Oh,
some
no,
of you.
no, no, not a problem. Now,
Oh,
thank you again. I think you'd be very gratified to see how many people on the chart here in the pictures are on this side of the Pacific, that you're having a world influence, not just in the West, but very much in the East. I'm looking at so many of our alumni. You have the whole classroom here. And oh my goodness, it's got to
oh
be
my goodness.
gratifying to you.
Hello, Mark. Listen, don't go away yet. I want to see who all is here. Thank you, Bill, for saying that. Yeah, no, I see that. I see that. I see that. Oh my goodness. Oh yes, in Swanee. Yes, yes,
Oh,
including.
yeah, there are many, many, many from over here.
Yes.
Yes. So,
Oh
uh,
wow.
so it's
Oh,
got to be
thank you.
you're
Oh,
expanding our in understanding. And again, you're the artist of interpretations. There's no question about it.
oh. Well, then thank you, Bill. As you're talking, I'm thinking one of the things that I have is I have a lot of courage. And I would wish we don't emphasize that as therapists, but I think it's just so important that we have the courage to give our all and to take risks, thoughtful, mindful risks, mentalized risks. My new word. But to have courage. And I find myself sometimes, Shireen's smiling on that one. I find myself sometimes just wishing that my patients could have more courage. And I do now talk more about courage. Courage to take risks. So, for example, like sometimes a patient will say, I did a consultation on a patient a little while ago, comes in for the one session and says, oh, well, I can't do that. I'm just so afraid I would fail. And of course, I'm busy thinking, oh my God, I wish I had more courage. But anyway, so I would fail. And they sort of feel that that's like end stop. Sort of that's it. Oh, well, then they can't do it because they might fail. And from my point of view, sort of like, yeah, so they would fail. So what would be the problem in that? I mean, we learn from our failures, right? But so many times people just stay stuck in a certain something and don't have the courage to break through to something new, different, and compellingly better. They just stay stuck and entrenched in the same old, same old. And patients do that. We therapists do that. And one thing that I've done as I've gotten older and ever more confident is kind of break free, and thus here it is. So thank you, Bill. And Midge. I love Midge too.
Okay, well, I think you'd be surprised in developing Model 6. I think you'd be very surprised to see how integratable everything you present is with our Christian world and life view that we, of course, here in our program function from. So maybe you talk
Interesting.
about that sometime. I have a doctorate in theology too, so
Oh,
yeah.
oh, oh.
So
And listen,
anyway,
and I see actually a few more comments here. Yes, people are very ready for my Model 6. I get 5 more years, Mark, Christine. I get 5 more years here. But yeah, no, that's encouraging. I think I want to say, I think I just say real quick, like while you're still here, thank you. Feel free to leave, and I won't notice. I will actually, but don't worry about it. The optimal stressor is a word that starts with D. I just want to say this is sort of tantalize and tease you, and certainly, Bill and Midge and Tyne will have me back. You all will have me back, and so on. There's a D word that's the optimal stressor in all of the models that is the cutting edge of the work that needs to be done. So in Model 1, classical psychoanalytic perspective, the cutting edge of the work is the optimal stressor that has to start with the letter D is Cognitive dissonance, working that through. Cognitive dissonance, like, duh, that's like, yeah. Okay, and cognitive, get that right? Model one, cognitive. All right, model two, what's the D word? What's the cutting edge of the therapeutic action? I've been talking about it today over and over again. I use the D word over and over and over again.
Deficit.
Disillusionment.
Oh,
What'd you say, Bill? What'd you say, Bill?
deficit, deficit.
Oh, deficit. Yeah, no, 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 that's good. No, no, no. That is good. That is good. That is good. Deficit would work. Deficit would work. Yeah. Yeah,
My
deficit or
my
disillusionment.
institute was from Cohut
Yeah, yeah,
in
yeah.
St. Louis. Yeah.
Yeah. Oh, yeah. Deficit. Absolutely. Disillusionment, deficit. Well, Bill, in your training, remember I said that with self-psychology, some of the folks sort of, it's mostly about holding, and consolidating ultimately that way. And
Right.
with others, it is more about the optimal disillusionment and then the adaptive internalizing as a result. What were you taught at your institute back then?
Well, oh gosh, my advisor was a Kleinian and object relations. So you're my grandmother into this, but as you know, Ronald Fairbairn's my grandfather into this. So I really learned Fairbairn there. Although most of them were trained and analyzed by Koha himself. They would go up to Chicago from St. Louis and come down, then come
Yeah.
back to St.
Yeah.
Louis.
Yeah, so there were different messages, different messages you received about the role of disappointment and working it through or not or
Oh,
whatever.
yeah, definitely, yes.
Definitely. All right. So thank you, Bill. All right. So in model two, then, the optimal stress cutting edge where the therapeutic action lies is in optimal disillusionment or deficit, or affective disillusionment, because model two is about affective, right? The corrective provision of self psychology. So cognitive disillusionment. Okay. Now in model three, what's the D word? Now, instead of in model two, we have absence of good, we have deficit. In model three, we have presence of bad that needs to be detoxified. Oh, that's a D word. Relational detoxification by way of negotiating at the intimate edge, projective identifications, the co creation, transference, countertransference, mutual enactment, negotiating it. Huh, done. Model four. Model four, what's the D word? Well, there's several D words. I do talk about, Masud Khan, who talks about this beautiful helping the patient overcome their dread of surrender to resourceless dependence. Dread is a D word, and dependence is a D word. So this is where sorry about my throat, my God. But anyway, this is where I have to just briefly tell you, and thank you. I know you're still here. So sorry, I know you haven't had your breakfast yet or haven't gone to bed yet or whatever. But anyway, all right. That so with Larry Hedges, he was driving me to the airport after I'd given a talk out in LA for 6 hours. He's driving me to the airport. The big LAX is looming. And he said, "No, Martha, you just have to have your Model 4." And I said, well, we have to have an R word for the defense and an A word for the adaptation because that's the way it goes. Not to be rigid, but anyway, that's the way it goes. And so we came up with, okay, well, retreat or relational absence for the defense. And then the adaptation would be accessibility or availability or authentic presence. So from relational absence to authentic presence, that's good. It's about the false self and the private self and existential humanistic and search for meaning. It's all good. So then we need a D word. And we were struggling a little bit. Now it seems sort of obvious it would be dread or would be dependence. We decided finally dependence, but then we needed to put an adjective in front of dependence because we have to have an adjective in front of these D words. And so we decided absolute dependence, Winnicott. But I didn't like the word absolute, but I thought, all right, okay, absolute dependence. I came home and sat down at my computer and I thought, well, it's an existential humanistic approach, actually. So I wonder what existential dependence would be. And I looked that up. I Google it, quote, existential dependence, end quote. And it said, depending upon another for one's very existence. And that is exactly what Model 4 is about. Regress to redo. It's about invitation to them to regress. Model 5, the D word is, we've already said that, disentanglement or decoupling. Quantum disentanglement, energetic decoupling. Quantum disentanglement. That's the optimal stressor. Now I'm getting to Model 6. Let's see if I can get this. So I believe that the D word, but I'm open to input from you folks, Mark and others. I know this kind of, Bill and all of you kind of got ideas here. I believe the D word is detachment, detachment, spiritual detachment. No, not spiritual. No, there's another word. I don't want spiritual. It's a somatic spiritual. There's some other word, something about detachment. All right, and you go from restricted flow to accelerated flow. Um, anyway, obviously I need to do more work on this, but I have another 5 years.
Well, yes, you do. By the way, Model 4, despair.
Despair, yes, thank you, is a very important word. Yeah, despair, yeah, yeah. And thank you. That's so beautiful and so brilliant, Bill, because Model 2 is about relentless hope. Model 3 is about relentless outrage, feeling victimized, et cetera, and Model 4, relentless despair. And Model 1 is about relentless conflictedness between defiance and compliance and a reluctance to commit. Right. I suddenly remembered what I've been writing about for the last several years. Anyway, so yeah, despair though, Model 4. Yeah, despair, existential despair. Yeah. Yeah.
Said Khan, yeah.
Khan. Masid Khan. hmm
Well, let us thank you again. And Midge, would you stay online? Midge, Martha wants to just to talk to you and on us about how you are.
Yeah. And just talk and touch base. I do. And I just want to say thank you to all of you for being here. I've got my eye on you, those of you whose faces I can see. Oh, thank you. I can't see everybody's faces. Oh, now I can. Oh, thank you. Oh, good. Now I can see your faces. Yeah, let me see your faces for a moment. Oh, there you are with the headset. Oh, good. Oh, good. And I'm going to the second page here. I wouldn't mind seeing Jeffrey again, actually, please. And let's see. I'm on the second page. I mean, oh, look at this. See more people here. Okay, good. Oh, lovely. Oh, Jerry. Hello, Jerry. Oh, no. Oh, it's very sweet. Thank you all for being here. You're right. Not to do any profiling, but I think many are more from your side of the Pacific than mine, than
Well,
our side.
well,
Can I
that
say that
is,
without being some
well,
bad word or something?
you don't realize, CBT has become institutionalized in the US and over here. And we're, thank you. That's a good validation. And we're primarily the only program of our kind in this part of the Pacific Rim. So to see this many people interested in following and advocating and to propagating has to be very gratifying for you.
Oh, wow. I mean, I suddenly just got it what you just said, and about you're the holdout, the stronghold, and the rest have gone to CBT and sort of quick, fancy dancy, quick
Yeah,
fixes,
yeah, it's
and it's
very,
heartbreaking. It's
it-
heartbreaking.
it's sad, and psychodynamic is being diminished along with the institutionalization of CBT
Oh dear.
in the US.
Yeah, I know,
Uh,
I know. And then I mean, it's just insurance companies and everything, and just and you got to have very specific, what it's very very. Very sad, like a dinosaur. I mean, yeah, no, I'm so passionate about this. And all of you who are still on when you could have slipped away and still on, which I so appreciate. I mean, I
All right.
really do. And you know my email. So did I say it somewhere? It's on the slides, the PDF. So let me say it. You could email me if you'd like. It's Martha Stark MD at synergy.med.solutions. So that's SYNERGY, med as in medical, MED, dot solutions, spelled the way you would think it would be, SOLUTIONS. That is the extension. So if you want to be in my SPOT supervision group, which is psychodynamic, psychoanalytic, it's my Stark method in action. And it's kind of cool. And then those cases get posted on my private YouTube channel. Private.
Okay, so everybody unmute and say goodbye and wave goodbye.
Bye. Thank
Thank
you,
you,
Dr.
Martha.
Stark.
Oh, goodbye.
Thank you,
Dr.
Dr.
B.
Bye.
Stark.
Ah,
Yeah.
thank you.
What?
Thank
Sharon and I
you.
heard your voice. I think that was you.
Yes,
Ah,
Martha.